thank you for joining in for today's Nomics webinar session. We are thrilled to have each and every one of you joining us tonight. I am Bani Jolly, a senior scientist at Karkinos Healthcare, and I will be the host for today's webinar. It's my pleasure to introduce our speaker for today, Dr. Saurabh Radhakrishnan, who will be speaking on CAR T cell therapy explained. Dr. Saurabh is a notable medical oncologist with extensive experience. Over these years, he has worked in the areas of medical and pediatric oncology at a number of profound institutions like Malabar Institute of Medical Sciences in Calicut, AIMS New Delhi, and Tata Memorial Center Mumbai. He has led several research studies and has authored articles that are well published in leading textbooks and journals. And he is currently serving as a senior consultant and director of medical oncology and precision oncology here at Karkinos Healthcare Services. Without further delay, I'll pass the virtual stage over to Dr. Saurabh. The floor is yours, sir.
Yeah. So, without much delay, let us start. So, what is a CAR T cell therapy and what is a CAR? So, it's a chimeric antigen receptor. So, basically, it is not a receptor which is naturally present in any animal or human, or it's an entirely artificial receptor. Now, basically, they are encoded using genetic engineering. And what they do, why is this? So if you notice this figure, this small thing and the tail going behind is the chimeric antigen receptor. What they do is they reprogram the T cell's ability to act against the tumor cell, which usually the T cell doesn't have. So that is the most important thing. Now, stepping a bit back, if we go a bit back into this thing, we know that our immunity comprises two aspects. One is the cellular immunity and the other is the humoral immunity. The cellular immunity involves predominantly two types of cells. That is the CD4 T cells and the CD8 T cells. The CD4 are known as the helper. The CD8 is a cytotoxic. These are regulated through what is known as a suppressor T cells, which regulate the overall immune response and also prevent the immunity from going overboard in the sense that destroying one's own tissues. On the other hand, we have the B cells, including plasma cells, which are the ones which produce antibodies and they destroy the foreign cells through antibody-dependent cell cytotoxicity and also directly intake into the cell, what is known as a cytophagy. There are multiple other mechanisms, but predominantly these are the two mechanisms and these form the bulk of the specific immunity that any animal or human being has. So the question that comes up is, how does a tumor or a cancer develop in the body? Now, if you look at it from an evolutionary point of view, all of us have at some point or the other have had cells and probably will continue to have cells that are, in the sense of carcinogenic or carcinomatous. So they are cancer cells. But because our antibody or our immunity, more appropriately our immunity, especially the cell-mediated, but also the other type, is able to recognize these as a foreign cells and they get removed. So at some point, if a cell develops an ability to overcome that, to escape the immune mechanism, then only a cancer will develop. So till such time, the cancer as a disease doesn't develop, all those cells. This is a very important factor to know. So our bodies are fighting, or more appropriately, our immune system is fighting not only the infectious diseases, but it is also fighting some of the alternate cells or atypical cells which develop in our body. But sometimes cells develop the ability to mask the antigens on its surface so that the cell-mediated immunity doesn't recognize the tumor cells. So in other words, it goes on to have very low immunogenicity and probably there is also antigen modulation so that the antigen with the tumor cell is requires and which is not present in a normal cell is not very clearly recognizable by the T cells. And another fact which many tumor cells, either from the beginning or during the course of illness, develops is they increase the activities of T regulatory or what is known as the T suppressor cells, so that these cells have a feedback effect on the cytotoxic and helper T cells. So these are some of the major ways which a tumor has to have before it develops into a cancerous growth. Otherwise, they will be just removed out by the immune system. In addition, the ability to induce lymphocyte apoptosis, and if in addition to that, the tumor cell also has an MHC1 defect, so major histochromatic complex defect, so that specific antigen which will stimulate a CD8 or the T cytotoxic T cells will not develop. And as far as the cytotoxic T cell is concerned, these tumors will not be there. The first 3 to 4 are considered the major mechanism by which a tumor cell may develop the ability to proliferate unchecked by the immune system and eventually leading to development of cancers in different parts of the body. So so this was something which was recognized early as late 1950s and 60s, and from that came an idea in not only for cancers to certain infections, because at that time there was not many antibodies, whether we can have some way of stimulating the immune system to fight any foreign cells. So it was in 1987, however, that at the Weizmann Institute, that the first chimeric antigen receptor, or more commonly known as CAR or CAR, was developed. And this was developed more towards cancer treatment, and that is where the major successes of CAR treatment has been. However, from 1987 till 2010, when the final trials came about and you had started treating patients, where the first success treatment came about, and finally in 2017, that's around 6 years back, the first one was also branded appropriately as Chimera, was approved for immunotherapy. The first approval which the CAR T got was for treating children and young adults with relapsed refractory ALL, so acute lymphoblastic leukemia. From then, the indications are slightly expanded, or the much work has to be done. Now, what are the steps by which a CAR T or a CAR gets come into the human body? How do you put it back? So the genetic engineering part, which is very technical, you develop this artificial chimeric antigen receptor, and then this CAR gene has to be introduced into a retrovirus. Now the retrovirus introduction, the retroviral introduction is mainly, sorry, the retroviral introduction is mainly so that it's much easier to take in. You have the RNA that goes back into the DNA, and the intake becomes that much easier, and more good and complementary divisions can take place. So you can develop a CAR against specific antigens on the tumor cells, depending on what antigen is very typical of that tumor. So the how do we go about for a patient? So the one thing to remember is, as of now, what we have for this therapy is specific for a patient. So you cannot do it from one patient to another, or in other words, the CAR T therapy is a drug which one cannot go and buy from the shop or from the factory. So prior to that, what is done is the T cells have to be remembered by the apheresis. So apheresis machine is a very common in very large number of blood banks, and most of them are able to, depending on the type of apheresis machine, some can remove the blood components, so you can have packed cells, WBCs, and platelets. So some of the machines you can adjust to remove the T cells alone. So the patient is connected usually by a central line in his arm to the apheresis machine. The blood, we think about a dialysis machine, somewhat similar to that. The same thing is an apheresis machine, but it's a different type of machine. The blood flows into the machine. It passes through the different components of the machine, where lasers and other components, and you are able to isolate the WBC alone, which comes into a separate bag. And the rest of the blood is again goes back into the patient. What next thing it does is, you collect these T cells, it is sent to the whichever drug manufacturing company which is going to develop the CAR for this patient. What is next done is these T cells are activated and also introduced to antibody, the specific antibody to the antigen which we need on beads, and this will then coat the cell with these antibodies. The next step is you have to allow it to expand. Now, expansion is one thing which takes some time, although we have ways of accelerating it. Still, it takes some time before the cell to expand and have a sufficient number which can be given back to the patient. Finally, the beads can be easily removed, and then this cell, which now has this antibody, gets infused back into the. There are 2, 3 other steps, some of which we will see in the subsequent slides. So basic important thing is that it has to be taken from the specific patient, and we have to isolate the WBC, which then goes to the factory. So the first step may be done, say, in Bangalore or Bombay or Delhi. The factory may be in Hyderabad. Initially, it used to be outside in the US predominantly, and certain France and Germany. And now we have CAR-T centers even in India where the drug this is being manufactured. So this blood had to travel all the way there. The steps which I mentioned just now, introducing them to antibody-coated beads and the activation and all the other factors would take place in the factory there. Once it had developed and had become in sufficient number, it would be sent back and used. So the procedure for the patient is relatively straightforward in the sense that it just involves taking it from the peripheral blood. There is no surgical procedure or anything involved. You just take this small amount of blood. It takes some time on the machine to do it, and then you give it back IV only. The cells can go into the blood and can home in on whichever cells it wants. So that is automatic. The homing part is automatic. But till that time, the patient has to be readied out for the procedure. So this is a multi-step process, and multiple teams are involved. One is from the drug company, one is a healthcare team taking care of the patient, the blood bank team taking care for the apheresis part, and the remaining infusions, if necessary, the critical care team. So the factor remains at the end of the day is that the drug is specific for that patient, and that drug which has been developed for that one patient has no role in any of the other patients to use. This becomes important later on. Now, one of the first antigens to which the CAR-T and its specificity was developed was what is known as a CD19 or a cluster differential. Basically, it's an antigen which is present on a B cell. And why this was selected was this is very common in what is referred to as B cell memory. So in the blood, as we said before, there is B cells and T cells. Now, the B cells, the commonest expression is that of CD19. Different types of B cells may have different types of other expression, but CD19 relatively remains in almost all stages of maturity of the B cell. CD3, for example, is similarly for T cells. So, but CD19 was developed. Now, and this is very rarely present in other cells. And so, in other words, the CD19 is a very specific cell for B cells. Now, the other important factor of why CD19 and some of the other molecules which are present like CD22 or CD20, it was not taken is that CD19 covers almost all the stages of the B cell where a tumor can occur. At the same time, it doesn't act on the primitive stem cell, the initial stem cell of the bone marrow, or what is referred as the pluripotent stem cell. This is very important. Otherwise, the stem cell itself might get destroyed, and the patient might have severe bone marrow suppression, and it might end up destroying many cells in the bone marrow, which may go on to mature into other forms of immunity. So avoiding that is very, very important. And one of the ways which we can do is if we select for CD19. One of the factors which is not covered by CD19 would be in plasma cells for malignancies like myeloma, where a different molecule, usually CD138 or one or two other expressions are available, for which we need an alternative drug. For most of the B cell, like ALLs, lymphomas, this CD19 expressor is drug is all that is required to control the growth of the tumor cells. So this is why the CD19 was the first cell against which Chimera and others were developed. Now, coming to the structure and the receptor, how the chimeric receptor remains is, it is similar to any of our immunoglobulin chains. Basically, there being four domains. One is outside the cell. This is the antibody domain, which will eventually develop, recognize our antigen. So this is the part outside the membrane, and this is the part which is involved in antigen recognition. This is the specific part, or in other words, for the chimeric antigen, this part or the outside part, outside the membrane, or what is known as the ectodomain, gives the recognition part. The second part is the hinge, and the third part is the transferrin. Both of them predominantly structured, although they are now putated to have certain specificity development program and abilities for the CAR antigen. And finally, we have the endodomain. It is in the endodomain, or the domain inside the membrane, that other newer developments for CAR T has taken place. Now, the ectodomain is the one which is involved in the specificity of the chimeric antigen receptor. It is also the one which gives the antigen recognition and initiates the immune process for the for that antigen CAR molecule. The spacer and the transmembrane complex are predominantly structured, but as I said before, they help to increase the exposure of the ectodomain to the antibody, to the antigen, and also increases the stability. And because the way it is present and how the antigen gets presented out will increase the antigen binding efficacy. This can result in increased efficiency for the molecule or decreased. So certain ankles you might get better antigen recognition, lesser ones may not get. Now, the third part, this is the most interesting from a view as of now, from a view of CAR T cell, because this is where, or the intracellular component, this is where, this is where most of the developments in the to increase, and why the ability of the CAR cells have so much increased is because of the changes that have taken place in them. Most of the initial CAR T cells which were mostly experimental was had only one in endodomain, and that was predominantly one which would activate the CAR T cell. The second generation which came about was later on added in the late 90s. This was because of the recognition that although the CAR T which we introduced with the cell led to the activation and they were fighting the B cells, unfortunately, some of them were very slow in replicating and increasing their numbers, because of which two things happened. One was our own innate immune systems might be more overcoming their actions. Second is the tumor might replicate much farther, much faster than the first generation one. So the second step was to add on a moiety which could increase the proliferation rate of the T cells. Finally, we now have the third generation. This becomes more important. This becomes more important mainly because this is the one which helps in persistence and also in developing memory so as to reduce the occurrence of relapses. So the three things, first generation was predominantly activation because of the recognition by the ectodomain. The second generation was where there was proliferation, and finally you have the persistent domains. So with the development of third generation, we actually have come into the clinical phase, because now you have ability to develop a memory cells also. The CAR molecule will induce some of the T cells to turn into memory cells so that relapses are much better prevented. So in addition to this, as I said before, some of the other methods which were used before were, one was adoptive cell transfer, too toxic, and the next was the immune checkpoint. Immune checkpoint, we have multiple drugs now. Vaccines are again coming back. The CAR T process was a thing which was somewhere in between the immune checkpoint blockade and adoptive cell transfer, because one was too toxic and one was taken much longer. Only we now have our cells for immune checkpoint. This is just to show that there was another way out of all of these, which was available to us, which took some time to understand out. So that has helped us now in developing the CAR T cell. Now, the CAR T cell as pointed out. Now, this is if you look at the date of this paper, which I've seen originally, it's way back in 2003. So at that time, what they have said ultimately, what a CAR cell should have is that a specificity for the antigen target recognition, plus it should induce the effector mechanism of T cell. So in short, a CAR, what it does, for what our slides have said, can be summarized in two sentences. One is specificity of antibody target recognition, and secondly, effector mechanism of T cells should have to be. Only then is this going to be effective in therapy. Now, this is a further modification of what I have said before. The only thing is nowadays we also have developed the fact that we have to transfuse and expand the patient's ex vivo itself to a very higher number while giving back, and further cause a persistence and increase in number in the body also. I'm sorry. Now, as I said before, there are 3 generations, much things take place. Now there's a 4th generation molecules are being developed, which comes along with a co-stimulating ligand, and they may induce some other changes, including genetic changes in the tumor cells, which may further help us in controlling. Furthermore, some of these changes will prevent recurrence or development of tumor stem cells in the patient's body. So this is still in a kind of a flux state now. We don't know what will be the reactions to this, and it's in a still an early stage of this thing. So this is what I said before, same things, beads and this the other things. Now, if you look at the left side, some of the factors which when we look into a CAR T cell is that one, of course, we need to know what is the target. So as I said before, CD19 was used for B cells because of 3 things. One, it's extensively distributed only in B cells, but no other cells. So if it is a tumor B cells, you have very large, the surface density of CD19 is very high for a B cell tumor. Normal B cells, not so much, and other cells not at all present. Second is then we construct the CAR. 2 factors involved, the targeting and the co-stimulatory domains. Finally, we need a vector, usually retroviral. Other forms are also now being developed. And third is the patient's blood is taken. There are other methods of doing it, which I'll come to in the later slide. The other 2 other steps which are very important, how to condition the patient. And finally, giving the drug and what are the toxicities. So these 6-7 steps are present for an entire treatment of CAR T cell. So coming now to the part of the clinical aspects and this thing, ultimately, how does this CAR T cell therapy destroy the tumor cells? Once the CAR T is activated, as I said before, the cytotoxic T cells attack, and the predominant mechanism through the T cells which have been activated by this to destroy the tumor is to increase the perforins, cause the electrolytes and other factors and other smaller granules to come out, and eventually leading to lysis of the cells. So the FDA has, as of now, this is US FDA, which has approved 5 molecules. Abicma, which is there for relapsed refractory multiple myeloma after 4 or more prior lines of therapy. So as of now, this is 4 or more, but as times pass by, we are hoping to have this to come up into earlier lines. The other one is Breyanzi. This is for patients with B-cell lymphoma, either DL after 2 or more lines, DLBCL, high-grade B-cell lymphoma, primary mediastinal B-cell lymphoma, and follicular lymphoma grade 3. So in other words, any of the aggressive B-cell lymphomas, you have the second molecule developed. The third molecule was Chimera. This was actually the first one which came about, and the only approval initially was for young adults and adolescents with relapsed refractory ALL. Later on for relapsed refractory DLBCL for any age group. The 4th one is Tecartus, which is for, again, relapsed refractory mantle cell lymphoma, which is very specific lymphoma, and also a very specific type of ALL, which is known as a B cell precursor ALL. Yescarta is another molecule. This is again similar to the second molecule which we mentioned, DLBCL, PMBCL, high grade B cell, DLBCL, following a transformation of follicular, and follicular lymphoma, especially in higher grade. Final one is Carvykti, which is again for relapsed refractory, again after 4 lines of therapy. Now, coming to the actual, so any of these drugs can be chosen. There are other drugs to understand, to develop. Some of the Chinese have developed, some other companies have developed other CAR-Ts. Similarly, occasional drugs are available in some of the other Asian countries. Indian drugs have also come along, and probably into the future, some of the predominant ones will come out of China, lesser extent, probably through Japan, and to an extent from India. This is what is expected because of the way the research is going. Now, the first step for a patient, once the apheresis has been done, so supposing a patient has come, we have taken up the apheresis and send it to the company for, saying the drug is ready and it is available now for the patient to be infused. We cannot just infuse it directly into the patient, because just giving it directly may end up causing the immune system to destroy all these new cells which have come up there. And that will also complicate further treatments or a second injection of any other CAR-T, because it would have severe immune reactions might take place. So what is referred to in transplant settings and others is known as a conditioning is done of the patient using what are referred as multiple conditioning regime. Although, so the most important thing that a conditioning regimen as far as CAR-T goes is to cause lymphodepletion. In other words, it has to lower down NK, B, and T cells, predominantly NK and T cells, and to lesser extent other B cells. This is predominantly done so that there is no rejection of the coming in cells, and there are no interactions between the coming in cells and other cells which are there. Second is conditioning also reduces anti-CAR-T immune, as I said before. It helps us to eradicate the immune suppressor, especially NK and T cells, which make up predominantly the immune suppressor part, so that the CAR-T can act much better in stimulating the cytotoxic T cells. It also reduces the IDO expression and increases co-stimulatory molecules, so that tumor suppressing effects are decreased. And it eliminates the hemostatic cytokines. The cytokines may sometimes be completely used up without having any action against the tumor, and there may be what is referred as cytokine expiry or cytokine exhaustion. So this will prevent that from happening. Now, what does the lymphodepletion? Why are we so much to lymphodepletion? Why is it important? If one takes a look at this figure, what the lymphodepletion helps us out is that it helps to change the lymphocyte so that there is a decreased number of endogenous lymphocytes. At the same time, there is increase in growth factors so as to help out CAR-T expansion. That for the tumor point of view, so remember the conditioning regimens always includes chemotherapy, may or may not involve antibodies. So by itself, these drugs are usually drugs which are used only in stem cell transplants, and the other molecules are usually not there. At least one molecule is which is predominantly used in transplant settings and may not be commonly used as part of treatment of these tumors. So it will reduce the number of tumor cells by itself because of the chemotherapeutic factor. It blocks other tumor cells from replicating rapidly. It also reduces the cytokine release from the tumor cells. This is very important because increasing number of cytokines may reduce the ability of the CAR-T to increase the number of cytotoxic T cells and activate them to release their cytokines. So, and finally, T cell exhaustion is also prevented because you have lymphodepletion has been done. So the T cells which is required, like the cytotoxic T cells and others, will no longer get exhausted because the tumor suppressor cells are no longer there. One major factor which has been told to have, nobody is very sure, is how it affects the tumor microenvironment. One is the T cell mesenchymal exchange, the reprogramming, and CAR T cell homing. Whether this is actually taking place, we don't know. And of course, other part of it, that is, it does reduce the suppressive immune cells, it suppresses cytokines. As I said before, previously, if you look at the slide, it reduces or eliminates the hemostatic cytokine sink. So these are the few factors why lymphodepletion remains. One of the commonest regimens used as of today, there are only 3-4 regimens which are used for conditioning in CAR-T, not in transplant. Transplant has a large number of other regimens. So one of the commonest regimen uses what is referred to as a flucide regimen or a cyclophosphamide and fludarabine. So during CAR-T or during any autologous transplant, the day the cell or the CAR-T cell or the other things are given is taken as day 0, and 5 days prior to that, that's why the -5, -4, -3, on each day you give cyclophosphamide 500 mg along with fludarabine 30 mg as shown in this product. There are other supportive molecules to be given for this. These includes antiemetics and others. It looks very simple, but there are a lot of complications which is going to happen with these drugs which we are going to give. And on day 0, so usually most centers prefer a 48-hour gap, although some centers say 36 or 24 hours are also sufficient. Although with fludarabine, most centers which I asked about seems to prefer a 2-day gap. But overall, there doesn't seem to be any wrong giving at least 24-hour gap also. But that's on individual treating doctors. But most centers prefer giving a 48-hour gap before coming on to day 0, and you give the whichever CAR-T drug you want to give. A minimum dose of 2 into 10 power 6 per kg of body weight should be there. So this, and other than this, the action will not take place. So what are the indications? Previously tried, we have lymphoma, myeloma, leukemia. That's it. 3 drugs, 3 major illnesses, and in none of these is first line. All have been relapsed refractory productions. So if you see a process flow of how to give one of the CAR-Ts, you screen the patient, see he's fit for all this procedure, entire thing, any medical specialty you take up, cardio, neuro, nephro, gastro, endocrine, show it to all the specialist doctors, ensure the patient's fitness, taking for leukapheresis, if necessary, 1 or 2 cycles of chemotherapy, routine chemotherapy for the disease can be given, what is referred to as a bridging chemotherapy. Then you give the lymphodepleting chemotherapy, and then you give the CAR-T, and then you keep him on follow. So why is CAR-T so important? One is, of course, which we have seen that in any situation, whether relapse, refractory, or anything, this drug is active. So for patients who are in 4 lines, 2 or 3 lines, and you are almost sure that the lymphoma or the myeloma or leukemia is already drug resistant, and again this will act. So most important thing is the activation of the immune response by the CAR-T is independent of the HLA, so that whatever mechanisms, as I said in the first slide, which a tumor cell may have to escape the immunity, none of this matters to the CAR-T because it's completely artificial. There is no way that for the tumor cell to act against it, and it will help us to activate the CD4 and CD8 cells. Second is because of the specificity of the ectodomain, you can have any form of target antigens, either proteins, carbohydrates, or glycolipid. Whatever you put onto the ectodomain, same things can come from everything. Third thing is, of course, you now by the 3rd generation CAR-T, you can have rapid generation of tumor-specific T cells. And unlike in an allogenic transplant, you don't have the possibility of GVHDA because entirely autologous. Although some degree of GVHD would be useful in some situations, here there is zero GVHD. So GVHD is a kind of a double-edged sword. Severe, it is life-threatening. Mild is always preferred in a patient, but fortunately or unfortunately, this will not happen with chimeric, and as of now, it is available because these are autologous. So basically, it's a living drug because it's very alive of the patient's T cells, and you give it through a single infusion. Now, CAR-T can have multiple side effects. The regimen itself can have multiple. CAR-T specifically has two major problems. One is cytokine release syndrome, which can cause capillary leak, and you need tocilizumab or anti-interleukin 6 to overcome that, and this can be life-threatening. Second is neurotoxicity, which can lead to seizures or confusion. In fact, it's relatively common that all patients undergoing CAR-T do get at least 1 week prior prophylactic anticonvulsants. One thing which one may not consider as a normal side effect, but a financial toxicity, is that the drug is very expensive. The Novartis molecule is approximately 4,75,000 US dollars. So this is the approximate same cost for most of the other molecules. Indian rupees, this would come to around 30 to 31 lakhs. So 30 to, sorry, 3 to 3 crores will come to approximately 3 crores. So this has always remained a problem. There are other issues with CAR-Ts that, as of now, as we pointed out, we have only 3 indications for CAR-T, and each one has the drug, the blood has to go to the company, it has to go there, then come back. How do we increase the indications that has to come? We cannot use it in a mass form. Only specific patients selected, then done. It's very complex, very laborious, although it is getting automated. And we need high quality voice. This is a very important factor. I think some of our scientists will be able to say much more easier, because this is going to be therapeutic and not just a lab room. We need a very good this thing. Most important problem is that each CAR-T is individual to each patient, and you need to have a very clear chain of custody. And these are very legal and important clinically also points for getting our CAR-T. Now, toxicities are multiple, as I mentioned before. So what NCCN, the standard guidelines for malignancy maintenance, say that a multidisciplinary approach is always required for CAR T cell toxicity. It's not going to be the oncologist alone who is going to manage it. And tocilizumab and cortisols or corticosteroids are our main options for most of our toxicity with CAR T. How do we follow up? Most of the patients after around 2 weeks, maybe 3, patients can be sent home. And 20th day of post-infusion, patient after, till then every week or every 3-4 days, you can see the patient. After that, he is to come back every 3 months for a year. If he is in remission, the patient requires at least a follow-up of 15 years. But you can increase the duration, maybe 6 monthly or others. Second is intermittently, we have to check the number of circulating CD19 lymphocytes so as to get an idea of how much it is. In addition to this, do a checkup for the disease also and whether they are coming back also. So there are multiple ways, where resistant, because it is now 2017 that it has come up, and now it's 2024. We already started earlier. Sometimes CAR-T, despite CAR-T, the disease can relapse. So one of the major mechanism is loss of target antigen, because some defect to the remaining tumor cells occurs. There can be tumor heterogeneity, so that multiple tumors, with some of them which have antigens, which will not have it. So in this case, CD19 may not be present in some of the few of the cells. And because of the selection pressures, that molecule alone will come up, and eventually you end up with something which is resistant to this, to the CAR-T. You can have lineage switching also. And more importantly, any increased PDL-X1 expression which occurs in a certain number of B-cell malignancy, this can prevent T-cell activation. Whether anti-PDL1s act and prevent this, we are still not very sure. That is being actively studied. But any increased PDL1 expression does have a chance resistance to CAR-T. And so this is in 2017. Much more increase in the number of molecules which are being developed. Before winding up, I would like to, one of the major things which have occurred in the past 3-4 months, one is the Indian CAR-T development, this was a result of a tie-up between IIT Bombay and Tata Memorial Bombay. And they have developed a CAR-T cell in India for Indian patients. And around in the initial phase, they tested it to 50. Now it's much high. This was the initial data. We have much higher number of centers for which the drug has been sent to. And a very large number of patients have now been treated by this. And in the initial, when the paper was published, 3 of them had completed. So all of these patients had multiple relapses and refractory disease, and 3 of them had achieved remission. Others were in the way of achieving remission. The cost of this is 30 lakhs. So it's still a high number, but it's nowhere close to the 3 to 3.5 crores which we are talking about the US drug. So remember, the 30 lakh is only for the CAR T drug. The rest of the chemotherapy, post-chemotherapy, antibiotics, antifungals, multiple supportive care, ICU care if necessary, the nursing, all of these are other additional costs. Approximately, we can add in another 20 lakhs to that. So it still remains an expensive option in India, but the use of the development of Indian CAR T has considerably reduced the cost, and probably with increasing use, this cost should come down further and further. And once we have developed one molecule, we know from previous slides that you can just change the ectodomain moieties and we can get specific molecules for specific diseases and using the same procedures. So this was the first patient. This paper, the patient himself has given permission to use in newspapers and elsewhere. This was the first patient who got a complete remission. First patient treated by CAR T in India by an Indian CAR T, and he continues to remain in remission. So what is the future of CAR T now? So remember, I have talked about all of it, including resistance and others and its adverse event. So it's not a miracle cure, but it is a cure in a situation where we don't have any other options. So, and the degree of remissions and cure is something which we cannot use now, because as per US FDA, a certain number of years have to go by before a patient is considered as curative. But it's very promising in many patients, not all. And as of now, we cannot say patients are cured, but they are in remission. Now, two major factors which initially there were some studies, then it went down, and once now with the success of present day CAR T, they have come back again. One is obviously solid tumors, because 80% of our adult patients, or 85, nearly 85% of the adult patients who suffer from malignancies have solid tumor, lung, liver, gut, or colon, or whichever area. And for those patients, we don't have a CAR T because their tumors are pretty heterogeneous. But there are studies going on, and again, 2-3 types of molecules have been. Some papers have come up, especially in gynecological tumors and brain tumors. And some of the studies are very promising. Maybe further studies in this might get through. Maybe next 5 years, we will know what is a solid tumor situation as far as CAR T goes. Because if it can break through that, that will be one major usefulness for a large number of patients. Second and more important is, as I said previously, most of our CAR T which is available now is autologous. In the sense that it is taken from the patient body and then it is sent to the lab to develop the CAR T, and then it has to come back. You cannot buy it off the shelf from anywhere. It's not readily there. So initially, when the CAR T was being developed, there were multiple teams doing both of it. Autologous from the patient's own body, which we have now, and allogenic, where donors gave their blood and they tried to develop a CAR T onto the T cell of the donor, and then that was used into the patient. But most of the others were destroyed off by the patient's immune system, because the entire cell was recognized as foreign by the patient's immune system. So the donated T cells were of not much use. Otherwise, we could have had a situation like in a blood bank where many people give the blood, you cross match and you give it. Although with the development of autologous CAR T to this extent, where you have 3-generational this thing, and improvements in our understanding of many of the blood tumors and how the immune system interacts, we are again looking into how to get off allogenic CAR Ts, and this is again becoming a topic of discussion. I do remember when the initial CAR T data was presented, I think in ASCO, or in ASH actually. So both the auto and the allogenic data were present. Allogenic data was a failure. The French company, which was a leading one in allogenic, their shares just crashed. So, but again, it is now coming back in European, especially where they are trying to do this. Some further modulations have been done apparently, and some degree of success is what some of the early press releases from these centers have said. although it's very early days. And again, as I say before, maybe in a decade's time, we might have an allogenic CAR T for our use. Thank you. Thank you, everybody, for the patient listening.
Thank you so much, Dr. Saurabh, for that very informative and very insightful talk, and for shedding light on this very important and currently very relevant topic, which is attracting all the buzz in the realm of cancer therapeutics. The floor is now open for questions. I request all participants to please send in your questions and queries in the chat box so that we can take them up.
I think Dr. Jyoti has raised a hand.
Yes, sure. Yeah, Dr. Jyoti, please go ahead.
Yeah. Thank you, Dr. Saurabh. Actually, it was a really, I mean, informative and very nice presentation. The question which I have is like, we require CAR T cells. I mean, cancer is a very common disease nowadays, and so we require CAR T cells to be for most of the people. So, is it like a biobanking an option for this? Something like a cord blood storage or any other thing which can be stored when the person is healthy? And of course, after research and or maybe after 10-15 years, everybody is going to be treated as a personalized therapy using CAR T cells, or maybe after some more years. But at that time, I don't know if people will have their healthy CAR T cells, or should it be done only before the chemotherapy? What should be done? Is biobank an option for that?
Not really, because the T cells are always present there. The present day apheresis machines are pretty good. So they can give you a high. The only thing it requires most of the time is patient to be on the bed for 2 hours, and you get a good yield of this T cells. Some patients they require a second session the next day also, but mostly that is enough. And unlike a stem cell where the numbers have to be stimulated out from the bone marrow, these are already circulating cells in the blood itself. So numbers are always so in that. But your question becomes valid if one starts saying the allogenic development. You know, donors coming and giving out their T cells.
Yes.
That's that is where the blood. The banking of these donated cells becoming, so that can be used for other patients, not for they can also use it, but other patients can also use it. So that is the situation today with cord blood. You're storing cord blood, it gets used by some other patient. Similarly, the donated T cells can be biobanked and we can use it, but as of now, allogenic, we don't have much data. The initial data was a failure, and now the research is restarted and they are looking at ways how to do it on the allogenic. So once off the shelf comes, then automatically the biobanking will also step up. As long as it is from the patient's own body, there is, I don't think, any hurry in doing a bio. It will not be helpful for you.
Okay. Thank you, Dr. Saurabh.
If any of the participants have any questions, you can drop them in the chat box or raise your hand so that we can take them.
CML, somebody has asked for CML. So someone has asked regarding CAR T for CML. Now, the CML has a very, I hope you know that the CML has a very, very unique this thing in the sense that there is a molecule referred to as BCR-ABL, which is the one for CML, and we have very effective treatments. You know, patients failing even the month back, the last, or what shall I say, the last resistance or the last stumbling block for refractory CML, that is the T315I. The drug for that has also come even into India. And we now have first generation, second generation, third generation pan-resistant CMLs and completely unrelated drugs, including abisinib, has come into India. So the treatment is very effective. In fact, if you see the data from the 90s and 2000s, a large proportion of bone marrow transplants in those days, at least I think the data was around 25%, was CML patients. And from there to early 2000s, by around 2007-8, that thing was to around 3% or something. And I think it should have further come down because by 2010, the criteria was they should have failed at least 2 generations of TKI or must have a T315I. Now with T315 drug also coming, I think the chances of a transplants are very low. So similar to that in CAR T cell, the possibility of using it is there. You can isolate the antigen using the which is going to which will be part of the BCR ABL. You can do a study and there will be correlated to the BCR. It may not, the antigen might be correlated to BCR ABL. You can develop the CAR T, but the financial aspects and the tech, the logistics of it may not be that very feasible, in the sense that very few patients might end up. I mean, I don't know, with the ponatinib and abisinib now available, how many of the patients will eventually require a CAR T for a CML is going to be very difficult. So the answer is yes, we can have CAR T for CML, but practically at present, I don't see any company developing it for such a rare and a very going into the future, a very uncommon situation coming up. That's why. Yeah, that is what I said. TKIs, there are resistance. So now you have abisinib for TKIs. You also have ponatinib for these T315I drugs. So both of these are there. So that is a point, you know. So you can have, there are multiple, but very few patients will be there. Maybe some company will develop if there are sufficient number. It is can be developed. There is nothing difficult in developing a CAR T for CML because it's from one clonal population. Like any most of the blood malignancies, it's from usually a single clonal population, and you can select out the antigen you want and then utilize it to develop. So that is not a point. Somebody has asked regarding minimum number of cells to be required. So minimum number is 2 into 10 power 6 per kilogram of body weight is the minimum recommended dosage of CAR T to come into the body to fight the tumor, to expand into a reasonable number down the 1 to 2 weeks, and to have a persistent one. Yeah, so somebody has asked, so this question, you know, where even if CAR T becomes very affordable, without lifestyle changes, will it be a cat and mouse game? Yeah, most of our cancers, you know, large proportion are you know, lifestyle related. But that said, today it's very difficult, you know, what for the patient, what is that? I mean, we can say that you smoked, you have lung cancer, or you did this, you have this. For some malignancies, you with any. So if you, but at the same time, if you look at the trans cancers for which we have CAR T now, you know, lymphoma, leukemia, myeloma, the problem is none of them have any risk factors. They are just relatively uncommon malignant, uncommon in inverted commas because they're not rare. They're not that common like a lung or a liver cancer, but they are there. They have a sizable number of patients out there. That is not related to any risk factors which are traditionally associated with cancers, you know, like smoking, alcohol, or any other issues and anything. They just happen. They can happen in pediatrics. They can happen in very young pediatric patients, very elderly pediatric. So in that time, so for these patients, you need CAR T. So that is the initial what we have. So every lifestyle change will make cancer rarer, but it is not going to be zero. So for the patient who is there, always will need treatment. So someone has asked whether this therapy can, yeah, at present we can give, but we have to find out why the resistance has occurred. So then has to develop a molecule, or do we have a molecule for that resistance? Then and only then giving a second CAR T. As of today, the CAR T is a single infusion drug. But theoretically, yes, you can have multiple antigen developed CAR Ts, which if one fails, we can develop a second one. So that will require testing for resistance to CAR T. There are mechanisms to check resistance for CAR T and why a certain CAR T will fail. Already we have ways where we can, as I said in that slide, where we can find out whether a specific CAR T will fail with a specific, or may not be that effective in a specific patient. So as of now, CAR T remains single, but theoretically, yes, anybody can be given multiple. Same molecule giving may not have any use because already the disease has overcome that. I will ask the technical team, we know that somebody is there. What are the technologies which we have developed for, you know, to assessing resistance to CAR T? Vinod is there. Dr. Vinod? I don't think
Dr.
Vinod.
Bani, do you want to take it up?
Yeah, sorry, sir, could you repeat that?
Yeah, no. Somebody has asked whether we can give CAR T multiple times, So what I said was that there is resistance to CAR T develops, and that is why CAR T is failing. So uh, how do we detect the resistance? And I have put the theory part over there, but the technical side develops the CAR T resistance testing and other things. So since somebody had asked the question, I was just asking if you could explain out how do you test for CAR T per se into an individual patient?
I think, in my opinion, it would probably be best to, leverage the NGS methodologies we currently have to see if the motifs to which the CAR T cell is supposed to bind is having any mutations that can cause treatment failure or resistance. So this is something that can be done even before we initiate, collecting or the entire procedure of using CAR T cell therapy for a particular patient. Since approximately a very significant proportion of the resistance mechanism actually come from either SNPs on the region where the cell is supposed to bind and so on. So yeah, I
Yeah.
think we can
I
utilize
think
it.
so. Basically, as Madam mentioned, it is the NGS technology again coming to us there. And we can predict as of now which of the patients are going to have very good response, which might have a poor response. So generally, a kind of a prognostication can be there. Even unexpectedly, sometimes CAR T fails, we can know why it has failed. And if we know exactly why it has failed, as of now, we don't have much CAR T molecules as per today. We have the 5 US ones and the Indian one, which has been, I think, one or two, the Chinese ones are there. But other than that, we don't have much of the molecules. So a second generation might come later on. Second generation, the drug, not the second generation of the car. We have already into the fourth generation of car. But the car as a drug, the second or third generation of car drug has to develop before we can think about giving it multiple times.
If there are no more questions from the participants, I'd like to ask just one last question.
Yes, sure.
Dr. Saurabh, how do you envision that CAR T cell therapy can be used for dealing with cancer relapse, especially in cases of hematological malignancies?
Yeah, so hematological malignancy, because as I pointed out, lymphoma, leukemia, myeloma, the main three predominant hematologic malignancies, we have CAR T. Now, the reason why CAR T got initially developed for hematological is most of the hematological malignancies are predominantly clonal. You have one molecule or one cell, specific cell, which is proliferating uncontrollably, or sometimes there may be mixed. But even then, you have a molecule or a CD marker, which is common to both of them. So commonly CD19 or CD138 in myeloma, etc. So going forward, CAR T is going to be there. Actually, what I envisage is gradually, I think it will come into the second or line. First line, we have very good chemotherapies, which are much less toxic in most situations. And to come into first line, it would have to be a really good study, which was market survival advantage over and above the chemotherapy without much toxicity, because the chemo combination has been used for such a long time. We exactly know how it works, what are the complications, and what is the cure rate. So up to second line, it will go rapidly. In my opinion, in the next 3-4 years, it will come rapidly into the second line. Whether it crosses the first line and becomes a treatment of choice in some of these diseases is something which we'll have to see later on. It will require some years of data maturation, because we are talking about cure rates for some of these diseases already in 90%. So that high is the rate of cure with some of the diseases, the routine treatment which we are giving now. So to overcome that, you need a drug which is really good, and comparing the cost is also an issue. So I'm not very sure of the first line. The second and third, yes, we are definitely there in the next few years for CAR T.
Thank you, Dr. Saurabh, for that very insightful talk. And thank you all of us for joining us today for this session. Your engagement and participation have made this webinar truly valuable. And before we wrap up today's session, I encourage all participants to post their questions on either our YouTube or our LinkedIn page if left unanswered. We also value your feedback and suggestions. So please take a moment to share your thoughts through the survey link that we'll be sharing with you shortly. And looking ahead, mark your calendars for our next webinar on May 25th, where Dr. Aarti Darra will enlighten us on homologous recombination deficiency. Once again, thank you all for your active participation today, and we look forward to seeing you at our next webinar. Thank you and have a good night.
Thank you. Good night, everybody. Good night.